Welcome to EEG Tutor. I'm your tutor, Dr. J. Case McKay. This is Lecture 6, EEG Artifact. This is an important topic that's near and dear to my heart. I'll try to make sure you understand the principles that will allow you to identify EEG artifact correctly, often even if you don't really know where that artifact's coming from, though it's always good to check the video and identify a source if you can. All right, let's get to it. So with this lecture, we're going to focus on EEG artifact. This is a huge topic, as we'll discuss further. Physiologic fields will be the first point of interest, and we'll discuss the difference between physiologic artifact and non-physiologic artifact with an emphasis on understanding principles to identify artifact, and hopefully you'll get a good foundation in this, and this will help you moving forward to identify even types of artifacts we haven't discussed in this particular lecture. All right, so to build on our principles, a waveform with a non-physiological field should be suspected to be artifactual. So what this entails is that epileptiform abnormalities and the cerebral waveforms the brain tends to generate will have a field that should be physiologic and logical, essentially. So we'll go through exactly what that entails in a second here. This was covered also in an article of mine with Dr. Tatum that was in Journal of Clinical Neurophysiology, or JCN. I would encourage you to check that article out. So EEG is designed to essentially just to record the brain electrical field, and it's really prone, however, to sources that are outside of the brain or extracerebral. Artifacts are commonly generated by these extracerebral sources, whether or not this is physiologic from body parts, this sort of movement, this sort of thing, or machines, which are going to be a non-physiologic artifact. When we talk about a non-physiologic field, what we are talking about is a field that doesn't really make logical sense. So we talked about how epileptiform abnormalities typically create an area that's more with a lower electrical field in the region of interest, a negative electrical field, which then is going to create a negative phase reversal. And when you look at a standard montage, you should see this played out as here, where you're getting to see essentially that it carries, henceforth in a very logical way, where each electrode is kind of going is compared initially to this sink in the middle that is negative. A non-physiologic field, you'll get phase reversals that don't really make any sense. You'll have a negative phase reversal, then a positive phase reversal, then a negative one again, which wouldn't make sense because this is the most negative part in the whole recording. So you'd expect all the arrows to sort of point towards the negative spot. This is how you should think about it. All the arrows should kind of point towards that home spot of the maximum negativity with an epileptiform abnormality. Whereas an artifact, you're not going to have that because it's not truly something from the brain with this negative kind of region emanating out that's being captured. To recap that a little bit more visually, we talked about this before, how when you compare E1 to E2, we used our little Cartesian system here, and that you would point the arrow down, and then conversely, E2 compared to E3, it would point up. So if there's an epileptiform abnormality here where it creates an electrographically negative region with the electrical field compared to these areas, then you're going to have a situation where all the arrows kind of point towards this spot, right? With a normal AP bipolar montage, of course, caveat. And so the field should be physiologic in this way. And that is a point I want to make, is that when we talk about this, we are often talking about an AP bipolar montage, which, if you review back to the original lectures, is the most commonly used standard reviewing montage. When you start to use alternate montages, there should still be very much a physiologic field, but it may not be quite as straightforward as what we've discussed so far here. So this is an example of a non-physiologic field. You can see here that this, for one, this field here it's maximal in the left central region, And also you see it in the right posterior region. So it wouldn't really make sense. Like, it should spread out gradually from here. It shouldn't just kind of pop up randomly in points of the head, but then otherwise not appear. So this is a non-physiologic field. It doesn't really make any sense how a field would propagate. So again, if it was physiologic, you would expect to see more of a gradual propagation from the central part out, the left central part out. So it would be here, here. You would see it here in the central part, whereas this is just all of a sudden in the right posterior region. And, this is someone actually scratching their head, which is why. So just an example of how you get a non-physiologic field with two maximum regions of electronegativity and amplitude, which really don't make sense if it's coming from one spot, if the waveform is being generated by one region of the brain. So this brings us back to this point of triple phase reversals. This is very characteristic of artifact, and to even think about what phase reversals are, again, is to look back. And a positive phase reversal is when the two regions sort of go away from each other, and you could write this plus sign in, whereas an area of a negative phase reversal is where the two waveforms come together. So when you have positive, negative, positive, this inherently is not a physiologic field, because a physiologic source, based on the graphic I showed you before and everything else, should not do this. It should be essentially the arrows should point in the same direction home towards the source in an AP bipolar montage. And so here's an example of triple phase reversals, and you'll be like positive, negative, positive, positive, negative, isoelectric. It's just kind of all over the place. Negative, positive, negative. And so this is a good way to know that you're identifying artifact. And again, another head scratcher here, a little bit more vigorous this time. Here's another example that uses the same slide we saw a few slides back, where you can see that it's essentially going to be like positive, negative, positive. You have to think, does this really even make sense? Could a waveform do this? If the answer is no, positive, negative, positive, then you probably are dealing with an artifact. This is one of the core principles of identifying an artifact I want you to take home with you after watching this. So, this has a couple features that kind of give it away as artifact, and this is an impedance check artifact. That's the first feature. It just says that right below there, and that should always be labeled, by the way. But also, again, you just see that it's like you really don't have a typical field sometimes where you have like a positive here, then negative. And it doesn't really make sense, like negative, negative, positive. This is more of a double phase reversal. Double phase reversals are a little less reliable than triple phase reversals, but should still be a clue to really question what you're looking at. The other obvious part of this is it's very monomorphic, and it starts and stops abruptly. And so it's extremely monomorphic, and this is more indicative of artifact when things are this monomorphic, are just kind of the same again and again and again. We'll go back to this principle a little later on in the lecture. For now, just take home this idea of the double phase reversal that's negative, positive, something to make you kind of question, is this an artifact? So when we're looking at artifact, we want to say, hey, is this physiologic artifact that we're generating from electrical fields of our own body, the patient's own body, such as eye blink artifact? We discussed this a lot in normal EEG. Sometimes the artifact itself is very useful to identify the state of the patient. Non-physiologic artifact is produced by the electrical fields of mechanical devices, electronic devices, and this can either be external or internal. So an internal device, you can actually have like a responsive neurostimulator or a vagal nerve stimulator, something that's actually implanted in the body can generate artifacts. So an external device is obviously something that's not implanted in your body. So, a ventilator, machines, causing water to move through the tube, things of this nature. So we'll get into that. Physiologic eye movements are very common, and it's good to be able to identify some of the basic ones, and we'll go through those. Some can be obvious kind of eye movement artifacts, tongue artifacts if they're labeled by the technologists correctly in that case. But there can be some unusual artifacts like tremor artifacts, myoclonus, shudder, and sometimes even psychogenic non-epileptic seizures, which can take a little bit of thinking using the principles we'll discuss to identify. Extraocular muscle artifact. So extraocular muscles can combine with eye movement artifact and can resemble spike and wave discharges. Very common in the temporal electrodes, you get this so-called lateral rectus squeak. And it can look a lot like this, or it can look kind of like spikes, though if it starts to intermix with other frequencies. You'd probably recognize this as not an epileptiform abnormality, but it's something to be aware of. You identify it by its very limited field, and you see it is happening with eye movement artifact, if you remember back to how that looks. Here's a patient with just kind of their vertical eye movements. They do have a kind of this lateral rectus squeak intermixed, and that could be a little bit of a fooler if you're not well versed in EEG. So you're just getting started as you're learning. That's very important to know about. Nystagmus itself can kind of create an odd-looking artifact, especially if you're not used to it. Notice how localized these fields are to the kind of frontotemporal region, and you have positive here, and then directly below it's more negative. And again, this is what sort of horizontal eye movements look like. So think of this sort of as slow roving eye movements or something of that nature, but much faster, because all horizontal eye movements have a similar appearance. So this would be like a horizontal nystagmus artifact here. Oropharyngeal artifact, or chewing movements, this sort of thing. Tongue, teeth brushing can often generate rhythmic artifact and can be confusing, especially if over-filtered. So it can look like this. This is a typical example of chewing artifact, and you're going to see it can look kind of rhythmic actually, but you probably recognize based on the other Awake EEG lecture that this is myogenic artifact, and this is from the masseter muscles and facial muscles and whatnot, and probably hard to mistake this as abnormal, but it is quite kind of rhythmic, and you have this intermix chewing artifact which looks like delta, so it can be kind of hard to say when you overfilter this if it's an abnormality or artifact. So it's always important to check your filter settings with the high pass filter. Make sure that's set at 70, so you're going to notice this is myogenic artifact. It's another example with a little bit more of a compressed time base to help you see a little better. And then this is someone who is brushing their teeth, and you see this, it's a little bit faster of a movement, and it's affecting more the right central region, and it looks like rhythmic theta. So, just kind of being aware of what's going on with the patient on video. If you see something that looks a little funky, can go a long way as well. So we just talked about this a bit, but really use caution when filtering the EEG. A lot of readers will automatically just start filtering like down to 30 hertz high frequency filter, and this is a mistake because often a big percentage of overcalls are due to overfiltering, where artifact is interpreted as abnormal. If you have to filter and you identify an abnormality, always turn the filter off and look at said abnormality independently without this kind of overfiltering effect to see if you still agree it is truly an abnormality. So here you have some artifact here that is unfiltered. High frequency filter is off. And so you can see there's a ton of artifact in this area, and you see these positive phase reversals, which kind of draw your attention to this maybe being artifactual. And here is when you filter it to review again. You see there's this little spike-ish looking area here, which is probably all artifact actually, based on its high frequency, its lack of physiologic field. It's like negative here, positive here, that kind of, it's like off kilter here and positive. So it's not really physiologic, but when you filter it, all of a sudden, hey, this kind of looks a little bit more, like something you need to pay attention to, but it's not. It's actually artifact, and you're over-filtering this myogenic artifact, and it makes it look abnormal. So keep this in mind as something that can cause you to stumble when you're just starting out. Here's some filtered chewing artifact, and it can start to look a little scary, like this is sharply contoured, generalized rhythmic delta activity, which we'll discuss more in a later record and kind of review back on some of these concepts. But when you start to over-filter things, it can look a bit more scary, like there's sharp waves and things in here, when really it's just the same chewing artifact we saw before, but with a different filter setting, which is now down to 15 hertz. So be very careful with your filtering and always look at things without excessive filtering, with normal settings of a high frequency filter of 70 hertz when there is an abnormality. ECG artifact is a common source of artifact. Your heart actually, as you know from EKGs, does produce electrical fields which can be detected, and EEG electrodes can also detect these same fields. Now the head's a little far away, but you can also either detect directly the heart or sometimes pulse artifact within the arteries itself near electrodes. And so what ECG artifact looks like is it's time synchronized with the single lead ECG below. One reason it's very important for technologists to obtain any good quality ECG recording. And this can look a variety of ways. Sometimes it can be quite diffuse like this, where you see these little kind of sharply contoured regions which are time synced with the ECG. This is probably the most common way when it's really severe that it will look. And here it is, and similar kind of thing in a reference montage, and you can often see the ECG artifact better in a reference montage, and you can see it as really time synchronized. And sometimes when you have just like a little less obvious of artifact, and you think, hey, is this discharge ECG artifact, or is it a real discharge? Putting a ear reference montage on will help you see that much better, to see, is this truly an epileptiform abnormality, or is this ECG artifact? Movement artifacts of the head or limbs can cause a lot of artifact, either from direct mechanical kind of involvement of electrodes, like the electrodes themselves are being moved against the pillow and whatnot, or from the actual electrical field the movements themselves generate. We hit on this a little bit with the teeth brushing artifact earlier, but you can have really substantial artifacts. This patient was being shaken somewhat by the family, and this region here was most affected. So this is a head tremor here, and it's really causing a lot of artifact. You can see again, this is not a physiologic field. That's a key part to identifying this type of motor artifact, whether it's a tremor or otherwise. As you see, this is maximal in the left posterior parietal region, but also it's maximal in the right occipital region, and its field is huge here, and then you really don't see it at all in the left central region. So it doesn't have a physiologic field that would spread out as a typical discharge would amongst electrodes surrounding the brain. And so this can be identified successfully as an artifact. Tremor artifact in particular often does generate sinusoidal kind of appearing activity, which can sometimes trip you up, making you think it's a seizure. And this is something I hit on a lot in my article with Dr. Tatum, so make sure, again, to take a read of that. But since the tremor artifact is quite rhythmic, it can be a bit confusing for either lateralized rhythmic delta activity or theta activity, this sort of thing. Essential tremor can lead to head involvement, which can really affect an EEG. So this is a tremor artifact, and you see these little kind of myogenic blips. They look sort of spiky. This is how EMG tremor artifact can sometimes look with the related muscle involvement. And so this is something to be aware of. And look how it's the same frequency again and again. It's in the posterior region of the head. And this is someone again with a head tremor, actually. And that's why you see it in the back of the head, because this is the part of the electrodes that's on the pillow, and it's kind of moving. It's actually moving with the tremor. And so it doesn't evolve or really have a physiologic field. Again, the field kind of rapidly fades away as you move anteriorly. And this is something that you can often identify by looking at the video component as well. This is an upper limb tremor in an ICU patient, and you have this rhythmic appearing theta. here, and it actually looks pretty physiologic in terms of it's at least all kind of left hemispheric. But you can sometimes identify these things by looking at the video, and also if you look down here, you can see that the ECG lead also has similar tremor artifact embedded in at times, and this is another great clue to see if there is an artifact. If you see that same finding in the ECG lead, then it's probably an external limb or some type of artifact actually causing the findings. Movement very commonly will affect the ECG as well as the EEG. And here's a person in the with upper limb tremor again, and you can see again that it's right occipital, real predominant. It doesn't have much of a field that spreads here in the parasagittal. And you can see it down in the ECG lead, which is a good clue again. So this kind of motor and tremor artifact, to bring it together, you can often see there's a non-physiologic field. Very frequently there'll be a sudden stop and start. You do often see phase reversals, as we discussed before, and you can get the bleed over effect into the ECG. And you don't see typically evolution with a tremor, and it's sort of the same kind of frequency range throughout. And it may come and go a little bit depending on how bad the tremor's affecting them or the position they're in, but it doesn't evolve in a frequency sense. One last kind of curveball that's worth discussing are psychogenic non-epileptic seizures. It's very common in epilepsy monitoring units, and it may result in movement artifact that mimics an electrographic seizure on EEG. And so this is because sometimes these movements sort of do evolve a little bit in some patients. Often they're kind of suddenly starting and suddenly ending, and they wax and wane with stop-start quality, this sort of thing that is characteristic of psychogenic non-epileptic seizures. But sometimes they can appear to have some pseudo-evolution. So, you want to look at these clinical signs of the patient on video as well. Is there a lack of a clear evolution? If there does appear to be some evolution, it's their eye closure, stop and go quality, asynchronous movements, side to side head movements, truncal or pelvic thrusting and predominant movements. And there's typically not a true crescendo decrescendo style evolution, but you want to look for that, but also just the clinical signs of PNES on video review. And then very importantly, as we hit further lectures, there's an absence of actual preceding EEG change in these patients because all the EEG findings you're seeing are due to the patient movement. With most electrographic seizures, not all, we'll kind of go through that, you're going to see some preceding change on the EEG that will be indicative of an electrographic seizure. Frontal lobe epilepsies, sometimes nocturnal seizures of frontal lobe onset, really can have hypermotor movements, which can sort of be very similar visually to a PNES episode. And they may not have actually a very good scalp EEG correlate before the event begins. This is one of the toughest findings. These events are typically occurring more out of sleep and directly out of sleep. And so that's another helpful clue for those that's beyond the scope of this lecture, but we'll tie in later. So here's some psychogenic movement artifact. And again, there's not a physiologic field. There's some temporal lobe rhythmic delta though that looks kind of like a seizure, and you start to see that. You say, "Whoa, man, that looks like maybe I need to look closer." You notice though it does start very abruptly. It doesn't evolve in a substantial manner. And you also see it has a non-physiologic feel where it's really maximal in the left frontal region, but also in the right posterior region at the same frequency. And this patient is shaking their head from side to side with their eyes closed, which is very characteristic of a psychogenic non-epileptic attack or psychogenic non-epileptic seizure. Okay, so that's physiologic artifact, and now we'll move on to non-physiologic artifact. The thing about non-physiologic artifact is it can vary incredibly in source, but often it is electrical devices, essentially pretty much always. So cell phones are very common now, and that's a source of EEG artifact. The actual electrodes themselves are probably the most common source of artifact you're going to see. Sometimes that can be the jack box itself. You can have devices cause artifact, IV drips, which technically some of that is not electrical. It's the actual movement of the electrical field of the water. So anything that is external to the body that's not physiologic of the body is considered external, like non-physiologic artifact. And let's go through that real quick. So single electrodes artifact are the most common source, as I mentioned. And this is due to a poor connection between the patient's scalp and the electrodes and or the connections of the electrodes to the machine. And there's often a high impedance greater than 10 kiloohms. This is identified by phase reversals within the channels that are involved, and they appear more or less like a mirror image. So this is very easy to see, but there's like a common shared electrode between two adjacent channels of kind of a mirror image. And what it looks like is this. So see how it's the C3 electrode that's high impedance, but you're basically seeing that there's this mirror image created by this C3 electrode being off in terms of high impedance. And this is very common in EEG, and sometimes it can make the discharges clearly look like positive phase reversals in between them, but sometimes negative. And so you have to be careful you don't get fooled into thinking they're epileptiform abnormalities when they're not. The way you can identify this is the very limited field. The field itself is just limited to these two sets of electrodes with one common electrode. So it's really limited to one electrode. And so that's how you know that this is a single electrode artifact, is only electrode pairs involving the C3 electrode actually have this artifact. So if there was a field that extends out physiologically somehow, which would be very hard with this waveform, then you would question this, would it be a single electrode artifact? But when it's confined just to really electrode pairs containing a single electrode like this, C3 one, then you know it's single electrode artifact. It can look kind of scary at times, but again, you see this is really confined to one electrode, C4 in this case, and it has, again, a mirror image appearance with these electrode pairs that share C4. Here's a bit more of a subtle example involving the F3 electrode of single electrode artifact. Notice it's a very, very limited field just to this exact electrode, and you're not seeing it at all in the rest of the recording in the standard AP bipolar montage. This one's a little bit more of a subtle perhaps, but you have it right here at T6, where this one's the one that's off, and it's real high amplitude in a mirror image. So we kind of hit this already, but looking at it and making sure it's confined to a single electrode is very important for identifying single electrode artifact. But sometimes if you have a little bit difficulty of telling exactly, a referential or transverse montage may be helpful to see if there's any field of spread. And remember that a typical waveform that's generated by the brain has a field which involves neighboring electrodes. This is absent in single electrode artifact. Sweat artifact is another common cause of electrode artifact, and the sweat can cause these kind of very low frequency, high amplitude oscillations, and the technologist may need to go ahead and dry the actual scalp and re-record if it's severe. So it can look a lot like this, which is sort of these massive kind of very slow delta waveforms that are pretty high amplitude, and this is very commonly seen in patients that are fevering, a lot of sweating, or just this sort of patient, and it can be quite difficult to interpret a recording with this artifact. So sometimes you have to re-record in this setting. 60 hertz artifact. The alternating current we use in the U.S. creates 60 hertz artifact. This is often seen in the ICU due to surrounding machines, and you get a lot of 60 hertz artifact in a mechanical setting like an ICU, and it can be hard to filter it all out and know what's left, if it's artifact like beta or is it truly just this filtered. But you can often remove it with a notch filter. And so a notch filter, again, is this filter which removes that specific kind of frequency band. And so what you see here is 60 hertz artifact. This is 60 hertz artifact with the notch off, okay? And this is an ICU setting. It looks terrible, right? And here's a bit more of a subtle example. 60 hertz artifact, still very much difficult to interpret this recording. It says very high frequency, dark looking activity. It's seen diffusely. Sometimes if there's one or two electrodes that are real high impedance, you may actually get it just in those electrodes and it won't look as diffuse. This is an extreme example. The same exact recording, you flip that switch and the notch filter to 60 hertz, boom, you're looking at this. You identify probably an epileptiform abnormality, a sharp left frontotemporal sharp wave right here. Anyway, so this is very dramatic in the difference that using the notch filter can make. So just be aware of that. In other countries, it may be the 50 hertz notch filter, depending on the standard of electricity utilized. A salt bridge is another type of electrode artifact worth discussing. This is quite different than the salt artifact we discussed before. This is when an electrode paste is too widely spread or too generously, and you get a bridge where it connects two electrodes together. This results in decreased amplitude in one electrode pair in the study. So this can be identified like this. See this kind of flat electrode here, this flat pair? This is a salt bridge from too much paste. So this is commonly seen. Techs really need to repair this. If you're a tech watching this, very important to repair these. Don't just kind of watch the whole study go, because it can be harder to see the field of propagation if you have too many of these, or you have one that's in the region of interest, and that can affect the calls. So you want to make sure this is repaired. RNS and VNS, neurostimulator artifact. This is machine kind of artifact, and I took some quotes out of this out of our paper again, and basically you get very sudden monomorphic sustained high voltage spiky bursts sometimes with RNS discharges, and that can be really important to note if a patient has a device, they're not overcalling abnormalities. VNS has diffuse high amplitude sharply contoured waveforms. Device artifact can be separated from ictal activity by its characteristic monomorphic, or like kind of it's the same morphology again. That's what monomorphic means, monomorphic appearance. And that's a good rule of thumb of all artifacts. If it kind of has the same appearance again and again, think about that. That can be something to say is definitely going to be a higher chance to be artifact. Here's an example of said artifact. This is the RNS artifact, very high frequency bursts as a device is discharging in the patient's head, actually, in this case. Ventilator artifact is a common source of external artifact, and it's a mechanical ventilator or respirator can produce artifact in two really distinct ways. One is direct respirations with a combination of the machine and movement, and then also due to liquid in the ventilator tube. You want to check with this artifact, if you suspect it, that it should kind of be occurring at about 12 to 20 breaths per minute, because that's typically how fast people are breathing on a ventilator. So kind of see this artifact every so often here, every 3 seconds or so, and this is a mechanical ventilator artifact. Very common in the ICU setting. Sometimes you can get this kind of higher frequency activity from water in the tube as well that can kind of overlay with the ventilator artifact, which tends to be more high amplitude kind of delta waveforms from the movements being kind of slow respiratory movements. The water in the tube artifact can look more like this, which is kind of high amplitude theta. It goes off as the ventilator goes. This is probably even better example. It's just more time compressed of water in the tube and ventilator artifact of the more traditional breath variety intermixed here. So a couple principles as we conclude before we hit the questions here. So some final thoughts. You want to look at artifact in a couple ways. You want to identify artifact as such by seeing a non-physiologic field where you have a maximal, field that doesn't really make sense, like two parts of the brain all at once. triple or sometimes double phase reversals, with triple being the stronger evidence than double. A monomorphic appearance, or a very kind of similar appearance again and again and again. Very fast frequency waveforms that are too fast to qualify as a spike, which is less than 20 milliseconds. Be very careful with your filter settings. Make sure your filter is not fooling you. And also just making sure that you are not missing time kind of locked waveforms with the ECG, and waveforms that are very clock-like, that just are completely rhythmic. You really need to consider artifacts. So those are a few bonus points to throw in there. Okay, it's quiz time. Let's check what you guys have learned. All right, question 1. What type of artifact is highlighted here in this slide? If you said sweat artifact, you'd be correct. Notice all these high amplitude, kind of chaotic waveforms, which, as we discussed earlier, is very characteristic of sweat artifact. Sometimes you have to re-record these studies, have the technologist dry the patient's head, try again, this sort of thing if it's out of hand. It's something to definitely be aware of and not overcall as polymorphic diffuse delta or something of that nature. All right, question 2. What characteristic of this record allows you to know that it's artifactual? Is it the high amplitude nature of the artifact? Is it the triple phase reversals of the artifact? Is it that it has a physiologic field, or that it's sudden onset? In this case, it's really this triple phase reversals. You can see sometimes where it's like positive, negative, negative. And this is something that's very commonly seen with artifact and not a physiologic seizure. So be aware of this as something to really be on alert for as you read a record, and this will help you avoid missing something and calling it a seizure or abnormality when it's simply artifact. Question 3. What type of artifact is shown here? Double phase reversals, sweat artifact, or single electrode artifact? Single electrode artifact is correct. And the reason you know that is this is more or less a mirror image where you see this here in this common electrode is F3, so that's where the problem is. So when you see this kind of isolated mirror image appearance to one common electrode, you can almost bet everything you have that is a single electrode artifact. Very common type of artifact. You'll see that all the time if you read EEG. All right, question 4. Is the field physiologic in this example? Yes, no, maybe. No is the correct answer, of course, because this is an artifact lecture, and you just don't see a logical spread of the field. It's real prevalent in the left central electrode and then also the right occipital. Doesn't make sense. A physiologic field should propagate through the adjacent electrodes. So that's a good way to recognize when something doesn't make sense and is probably artifactual and not physiologic. All right, we have some references. I'll also add that Tatum's EEG artifact atlas is a big part of this lecture, and really just consider that number 4. All right, I'll add that after the fact. Well, thank you for sticking with me. I'm your EEG tutor, Dr. Jake McKay. It's been really a pleasure to talk to you about EEG artifact. You stuck with me all this time, and next week you finally, and let me say finally, get to the lecture covering epileptiform abnormalities, and it will be a doozy. It's going to cover the IFCN criteria, some other criteria that are common rules, and we'll basically systematically build up for you how to know if something is truly epileptiform or if it may be a benign variant, artifact, etc. So it will build on everything you've learned to this point. See you next time.